everyone. Welcome to the Premi Chats. Premi Chats is a program that is for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I'm a Premi parent and executive director of the Canadian Premature Babies Foundation, and I'm happy to be your host today. Premi Chats was created by the Canadian Premature Babies Foundation, also known as CPBF. The foundation is a parent-led organization that helps families in and after the NICU through education, support, and advocacy. If you have a heart for preemies, whether you are a family or a healthcare professional, please check our website at canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who want to see our little babies thrive. If you're watching live, please bring your voice to this table. Leave your comments and questions in the chat, and you try to address them during our program. It is through rich conversations like this that we can advance practice and learn together. And today we are going to talk about the parental role in preventing IVH and nurturing the brain to improve long-term neurodevelopmental outcomes. Dr. Mohammad will offer his perspective as a physician, and Flavia will share her experience as a mother. Her daughter was born at 23 weeks. There was extremely high chances for her to develop IVH. Preventative interventions were in place and immensely contributed to her not having brain bleeds. And today, we're going to talk with Dr. Khorshid Mohammad, who is a staff neonatologist at Alberta's Health Services in the Calgary Zone and a clinical professor of pediatrics at the Cumming School of Medicine, University of Calgary. He's a founding member of the Newborn Brain Society, chair of the Society Educational Committee, and member of the board of directors. Dr. Mohammad's quality improvement work led to significant reduction in mortality and brain injury in extremely premature infants and term infants suffer from asphyxia and seizures. Dr. Mohammad received the Canadian Pediatric Society Emerging Leader in Neonatology Award in 2020. His areas of research interest are education, brain perfusion, monitoring, and quality improvement, neuroprotection strategies. And I talked to Dr. Khorshid yesterday because he's not in Canada today and he was in transit. So I recorded this video and it's amazing information there for everyone working in this area and the results of all the work that they're doing here in Canada for brain protection. I'm going to share his video. We did a Q&A. It's fascinating, the work. And then we're going to go live with Flavia, whose daughter was actually Dr. Khorshid Mohammad patient in the NICU in Calgary. So let's play the video and we can chat right after. Dr. Mohammad, thank you so much for joining me here today. Always a pleasure having you. I'm very excited about this talk and what else is happening in your world with neonatal brain.
Thanks, Fabiana, for inviting me again to present at the Premi Chat. I really enjoyed the first time and I'm excited about the second time because we will be talking about the neuroprotection from completely different angle. And what's new in the newborn brain and neuroprotection is that we have published our data on the IVH prevention bundle, and it shows that it did significantly decrease the incidence of death or severe neurodevelopmental impairment and decrease the incidence of cerebral palsy. So I'm excited about that.
Oh, thank you. I'm very excited about that too. So let's share your slides. If maybe you can talk a little bit louder would be great, but then we'll come back after for Q&A. Thank you.
Okay, thank you very much. Hello, everyone. Today's talk will be about nurturing the premature brain. We wanted to bring it from parental perspective. We usually present these talks from the physician perspective, especially if it's being given by a neonatologist. But today I thought I'll bring it from the parents. Before doing that, I wanted to show you three main graphs from three main publications of the IVH prevention bundle. This was a QI project in Calgary trying to implement a quality improvement bundle to decrease the incidence of severe brain injury in premature baby born less than 29 weeks gestational age. The graph on the top left showing the results in inborn babies in our center and shows after the implementation of the bundle, we were able to decrease the incidence of death or severe brain injury significantly, and we sustained that over time. We controlled for all kinds of confounding factors, and we also did interrupted time series analysis and was still significant. We tested that in outborn babies as well, and that was still holding after doing the interrupted time series analysis. And eventually, and most importantly, we looked at inborns and outborns, the impact on long-term neurodevelopmental outcome. And we were so pleased to see that the implementation of the QI bundle, which did not include any fancy intervention, basically everybody or anybody, any center, any NICU can implement it. And we were happy to see that it did decrease the incidence of death or severe neurodevelopmental impairment significantly. And again, we have control to the we controlled 4 compounding factors, and we also did interrupted time series analysis. It did also decrease the incidence of cerebral palsy that was clinically significant, but it wasn't statistically significant. And really, the quality improvement always confused me. What's the difference between quality improvement and research, and where the research stops and the quality improvement starts? And eventually, I was able, at least for myself, to understand the difference and the relationship between the QI and research. QI really is dealing with systems. Research is exploring uncharted territories, bringing the ideas from the bench to the bedside. And it's estimated that it takes between 10 to 15 years for an idea to come from the bench to bedside. And those ideas are so precious and important. We need to give them the best chance when it comes to the bedside. And QI is the methodology to give that idea the best chance. It works with systems, and it tries to decrease variability in the system. For example, the publication that we published, you can see here, the variation in the system was very high before the implementation of the bundle. And after the implementation, the variation decreased, but there was still variation. Over time, when we continued to implement our quality improvement, the variation decreased. It will never be flat. That will mean the environment is so cleansed, it's not real life. There will always be fluctuation, but the hope that the amplitude of the fluctuation around the targeted outcome decreases. And that means your quality improvement intervention became the new norm. Other groups, institutions, and researchers showed similar impact of the neuroprotection bundle on the acute brain injury in premature infants, but at least a couple centers showed that it wasn't that effective. So sometimes, despite your best efforts and best intention and implementation, the bundle might not work. So what do we do in those cases? How do we approach the families? Do we tell them that all the statistics that we have about cerebral palsy and the outcomes, or do we tailor our conversation based on the family's need, family's goals? And that's where it becomes important, the skill of understanding the family's needs and using them as partners, not as a patient. And I love this quote where it says, numbers implies trends when stories acknowledge the chaos. Today, I will be talking about some of the chaos cases, some of the chaos stories, and I will go over a few of the mother stories and what I have learned from them and how I have changed my practice based on my conversation with those parents. So I start with Harper, and Harper was an example of a mother who was labeled as difficult mother. So this was a 23-weeker with no steroids, had all kind of complication at the acute course, at inotropes, ventilated, CO2 fluctuations, and then we had the head ultrasound, the acute head ultrasound on the top left, you see the hemorrhage here. It's periventricular hemorrhagic infarct. That's what we call it. We used to call it grade 4 IVH. And eventually, this area became porencephalic cyst, means there is white matter loss, and it left a hole inside the brain. So our team would approach this mother, and we will tell her that, oh, this was a 23-weeker, no steroids, still ventilated, and has grade 4 IVH. I think it's okay to consider changing the goals of care. And each time the mother was furious and she was reluctant, said, please stop telling me about the outcome. I don't want to stop the care. I don't want to change the goals of care. And each time there will be a background conversation, sometimes, not each time, that will say, we don't think that's really getting it. She's probably still in the denial phase. Eventually, she will understand and maybe she will change her mind. So after a while, Yulia sent me these pictures of Harper doing great, running and talking, and you can't tell that she has any motor deficiency. So I have learned to listen to the parents. I have learned that really the mother, the parents are the one that makes the difference and change the outcome in this baby. We should never label any mother or any parents as difficult parents. If we are finding difficulty conversing with them, then there's a problem from our side that we need to fix. The second story is the story of a term baby, Emerson, who had moderate HIE, and the MRI showed brain injury. And then I counseled this mother, and I talked about the neuroplasticity and all the good outcome if we put the baby in a positive, interactive, loving environment. I usually follow up with the families if they wish to talk about the NICU care, if they have any questions. So I met with this mother, Tara, and the two things I have learned from her. One, she said, you have never explicitly mentioned the term cerebral palsy, and it was a complete surprise for us when we went to the clinics and pediatrics, OT, and PT. So I learned from there to, in spite talking about the neuroplasticity and positive outcome and keeping the hope and trying to avoid labels, it is important to mention the terminology because it can be traumatic to the parents and families when they meet with the physicians in the clinics later on. And the other thing I learned from Tara is the use of stem cells and the fact that there are lots of stem cells in the breast milk, and that changed our practice. We started to feed babies with HIE during cooling, where we were keeping them MPO, with the hope that there will be some stem cells in the breast milk that may protect the brain of this HIE baby. And then the third story is the story of Raya and Yusuf. Raya and Yusuf were 25-weekers, twin, die, delivered by emergency C-section. Mom had only one dose of steroids. And Raya had all the complications that we hope the baby will not have in the NICU. They were intubated for a long time, had lung collapse, PDA, ligation, CMV infection, you name it. They had all those complications. And despite our neuroprotection bundle, Raya had grade 4 IVH on the right side. And like Harper, there was porencephalic cyst on this side. And Yusuf had bilateral grade 3 IVH and post-hemorrhagic ventricular dilatation after that. And of course, also we counseled this family after the 23-weeker case and other cases. We changed our practice, the way we counsel the families and engaging them. We talked more about neuroplasticity and the positive interactive environment, still mentioning the terminology of the outcome like cerebral palsy and neurodevelopmental impairment, but following that by the neuroplasticity talk. And this is the video showing the progress and the outcome of Raya. Of course, all these videos and pictures are with the permission of the parents. And you can see in this video that Raya went through this NICU, usual NICU course, and then eventually she started to walk with difficulty, and then she was running. And yes, she had the cerebral palsy, spastic diplegia, but this label never defined her and never deterred her from thriving and be happy interacting with her brother and her mother. And that's not all, because her mother decided to go back and study and become a NICU nurse. I have met her 2 weeks ago while I was on service. She was doing her orientation to become an NICU nurse, and now she is a practicing NICU nurse. That is the power of a mother. They can move heavens and earth to change the outcome of their babies. Their uh, their impact on their baby's future is way above and beyond any interventions that we have in the NICU. This is a couple of publications that really put me on unease. It's unsettling. This was a paper, one paper published by the Dr. Miller's group and another paper as well, is showing that the socio-economic status was more important than the brain injury itself, meaning if the parents had high education or good socio-economic status, their babies had better outcome. And I started to wonder, why is that? Why the parents need to have high education? Why the parents need to be rich for their kids to have better outcome? The ownership is on us to make the intervention available for the parents. The only explanation I can make this is uh, speaks to the health disparity, that we weren't successful to make our resources equally available to all parents. The parents have to fight their way through to access those services. Those parents who are vocal, who know how to advocate for their kids, they got better outcomes. When the parents who are poor, maybe English is their second language, maybe they are immigrant, they weren't strong enough or they weren't connected enough to get the resources that will change the outcome of their kids. So we need to do better. There's a lot to do. These papers are very important and highlighted really unsettling fact with the deficiency in the system that we have, the healthcare system. And this is one approach to talk with the families from their perspective rather than having this template base of explaining the MRI, neuroimaging, and the outcome of their kids. And that reflection, humility, sometimes we don't know, and we need to acknowledge that we don't know what this means, we don't know what this EEG means, we don't know what this MRI means, etc. And we should be open-minded because we listen to the parents, see what is your goal, what do you want from this conversation, then we guide our conversation based on the parents' need and parents' goal. And we need to partnership with them and engage them to the conversation. It's really important. It's the first thing you say, set up the rest of your conversation. The parents live with that MRI for the rest of their lives. Always, the minute you talk about the MRI, the rest of the conversation, the parents will say, what about the MRI? You talk about their baby and their health, but say, what about the MRI? What does that mean? What does that brain injury mean? So we need to prep them. We need to talk to them. We need to guide our conversation and tailor it based on their wishes and their goals, not using these pre-prepared templates to talk with the family. And now I will finish up my part with Lena's story. Lena was a 23-weeker plus one. There was no antenatal steroids. She had sepsis. They removed her PICC line because of that. She had spontaneous intestinal perforation. She had Penrose, MPO, antibiotic, PDA opened again, and there was massive pulmonary hemorrhage. She got multiple blood products, medication, and intervention. She switched to high frequency oscillation sensor medics, and then she arrested. The physician who was taking care of it, it was during the fasting month of Ramadan, and it was beyond the time that they need to break their fast. He kept resuscitating her. the team was thinking that guy is crazy because they were going beyond 15 and 20 minutes. And the physician were mentioning, no, she is looking at me. I know she's there, whether that was a hallucination because he was hypoglycemic from fasting or not. But that what saved Lena. Lena came back and she was revived from that cardiac arrest. And now here is Lena with her hero who resuscitated her. She visited us in the NICU, and she's been followed by his wife, who is a pediatrician. And this is Flavia. What I wanted when I pass it to Flavia now is to really tell her story. Although when we present the story, we present the good outcome, but behind that good outcome, there is lots of tears and sweat and frustration, being judged and being angry about what's happening, what's going on. But as a mother, they will keep pushing until they get their baby to the best outcome for them, and that's what makes them happy. So Flavia, the floor is yours. Thank you very much for coming forward and presenting to us your story.
Hi, Dr. Mohammad. Thank you so much for your presentation and for this outstanding work you are doing here in Canada. And I do hope many other countries follow this incredible bundle. But let's talk a little bit about the bundle because it might be new to some people listening to us today. I just wanted to talk a little bit about how was the implementation, what is the bundle, and how do you actually talk to families about the neuroprotection those first 72 hours?
Mm-hmm. Thank you, Fabiana. So the bundle basically it's a quality improvement project. What we did, we studied the risk factors in our unit, and we identified risk factors for IVH. Then we looked at those risk factors to identify the most important one, because if you target all risk factors at the same time, the unit or the team will have this intervention fatigue, and you ended up not preventing any of them. So we ranked them the most important to least important, and then we had another ranking, which one is more feasible in our unit to start with. And based on that, we divided them into systems. This is related to hemodynamic system, this is a respiratory, etc. And once we have done that, we spread it over time. This is a prenatal risk factor, this is an outborn risk factor, this is the around the delivery risk factor, and this is within the first 72-hour risk factor. And then what we wanted to do is we wanted to shorten the window, because if you have a long window of intervention, again, the compliance to your bundle will become less and less. People will get tired over time. We wanted to shorten it so it won't create that fatigue. And also, on the other hand, we wanted it to be long enough to prevent the outcome that we are trying to avoid. And that's where we discovered the 72 hours window. We looked at our data and the published paper. We found that most of the IVH, almost more than 90% of it, happens within the 72 hours. We said if we can prevent the IVH in the first 72 hours, the chances of it happening after the 72 hours is very minimal. And then we won't need to deal with the post-hemorrhagic ventricular dilatation complications and intervention. We won't need to deal with the grade 4 IVH or periventricular hemorrhagic infarct. And that's where we arranged everything. We got the stakeholder engaged, and then we approached the nurses because they were the one who implemented the bundle. We started to do some teaching, and we implemented the bundle. We set 1 year. We said in 1 year, our goal is to decrease the severe brain injury by 50%. We intentionally made it ambitious because that built the momentum and anticipation. The team felt challenged that we need to reach this 50% reduction of the severe IHPH. Of course, we worked also on the classification. We want to make sure the outcome that we are measuring it the same way. So we work with our neuroradiologists to standardize the classification of the brain injury in premature baby, and that became standard in the rest of Canada. We created a task force where we worked on the classification, and we published a paper from the Canadian task force on the standardizing the classification of the brain injury in premature babies. The interventions, the main interventions, if I would pick from the bundle which one works the most, was the use of inotropes. We used to treat hypotension based on the echo markers, based on the measurement, despite the baby would be clinically stable. So we changed our mindset. We said as long as the baby is stable, the vital signs are good, we will not screen these babies with echo and we'll leave them alone. If the baby becomes clinically symptomatic, then we will use the echo to guide our intervention. And then we had this combination between the echo, blood pressure measurement, and clinical markers. Say that if you don't have those two, don't treat with inotropes. And by doing that, we decreased the use of inotropes significantly, and we published the data. The second key intervention was minimal handling. We said we'll leave these babies alone as long as we can, and if there's no clinical need to go and handle them and do intervention. And the byproduct for that was unintentional. Because we were doing minimal handling, the team perceives that the baby is stable. Our use of sedation and opioids decreased significantly after the implementation of the bundle. The third one was delayed cord clamping. Again, for the same idea, once you have delayed cord clamping, the chances of hypotension and hemodynamic instability decreases. And that was another important intervention, I would say. Standardization of intubation and extubation was another one. The auditing itself, when we developed our standardized auditing of the variables, by auditing the variables, you can decrease the incidence of IVH, and other groups has shown the same because you are creating consistency, you are streamlining the language. So how would I approach the families? I would talk to them about the bundle because they would see the sign of sleeping brain and the clock where this will finish at this time. And we would tell them this is no reason that you cannot talk with your baby, you cannot go and touch your baby. Those are the nurturing moments. They are moments that baby needs them. And we said if we are keeping the baby intubated and we are not allowing, I hate the word allow, but we were using it, we are not allowing you to hold your baby, but you can still go in, you do facilitated tucking, you touch your baby, you talk, you sing, whatever you want to do is still possible. And as soon as we can take the baby out, then you can do the kangaroo care, which is very important. And then I'll explain the rationale and why we are doing this. And they were all receptive to it.
Well, that was my question actually, because you're talking about kangaroo or skin to skin from the moment of birth. So, but the bundle does exactly the opposite. You minimal handling for the first 72 hours, and then you do skin to skin. So, where is the community? Is the community divided on that? Do kangaroo care right away or don't? Because some places in the world, they are doing kangaroo care on extreme preterm baby right away. So what is your position, and how is Canada sitting on that decision as a system across?
Yeah, no, that's a very important question. What we encourage kangaroo care as soon as possible. What we said, if the baby is incubated within the first 72 hours in the critical window, we don't do kangaroo care. But if the baby is extubated and on CPAP, as long as we are not doing extreme turning of the head, we give the baby to mom and they do their kangaroo care. This may change if we implement the rest of the elements of the neuroprotection bundle. As long as we are careful, we are keeping the head in the not midline but not extremely turned, we might be able to do the kangaroo care as well, knowing that it is very important for the mom and for the baby with all the outcome that we know and the impact on the brain.
So my next question is about the age of the baby. Does it have a difference when the baby is extremely preterm, like the nano premi that I just heard of the term this weekend, 22 weeks versus a baby who was born at 29 to 30 weeks?
Yeah, so the bundle was targeting babies born less than 29 weeks gestational age. And that's another discussion we had. We said, should we target less than 33 weeks or less than 29 weeks? We thought if we target less than 33 weeks, suddenly your number of babies to implement your bundle massively increase, and the chances of the team implementing the bundle decrease. Also, babies above 28 weeks gestational age, the risk of IVH is much less than the ones born less than 29 weeks. So we said, let's target the most vulnerable population, because we suspected that if we create the culture for these tiny babies, it will just propagate to the bigger babies. And sure enough, that's what happens. Now, all babies want the babies less than 33 because they were getting minimal handling as well in the unit. But the main target population was less than 29 weeks babies.
Okay, my next question, you talk about counseling families, you talk about neuroplasticity, if you see there is IVH of any level, and you discuss counseling and neuroplasticity. And a lot of us parents who have a child with a neurodevelopmental impairment, my son has cerebral palsy, we always talk about how we were giving news in the NICU about the brain and the potential of our kids having a diagnosis. But the question we always ask ourselves, parents, when we work in collaboration with researchers, is the NICU a place for diagnosis, knowing that the brain can still recover in some cases? So what is your take on that? Because that is a big discussion for families when it comes to break difficult news for them.
Yeah, that's a great question, and it's still up to debate. We were just debating it yesterday and today at the conference that I am at, whether we need to do term equivalent MRI or not, or what's the value of doing cranial ultrasound. The way I look at it, and doesn't mean it's the right or wrong, I separate the purpose of the neuroimaging that we are doing. Are we doing it to counsel the families, or are we doing it as an outcome measure to test our intervention to see if they are working or not? And I think as an outcome measure, it is important, because then that's the only way to know whether we are doing good or not, whether our intervention is working or not. And also when we are benchmarking center to center, that's how we know where we are with our intervention and outcomes. However, when I talk with families, I become more descriptive. I show them the images, because there is grade 1 and there is grade 1. There is a tiny grade 1 and there is big grade 1. Same for grade 4. There's tiny grade 4 and there's big grade 4, and their outcomes are quite different. I think it's important to know the outcome, Fabiana, because then you can enroll them in early intervention programs, because if you have a general movement assessment and you can predict CP earlier than 1 year, you can introduce the early intervention programs and you improve the outcome of cerebral palsy. Now, this has to be packaged with the correct neuroplasticity conversation, because if you give this to the families dry, it's so traumatic and defeat the purpose. We all become fixated on the label. We all develop this label locked mind. And whenever our child is on the border of the normal spectrum of development, we all immediately, our mind will say, oh, this is because of the cerebral palsy. I can't do anything about it. And the fact we are telling ourselves we can't do anything about it contribute to the outcome. And our positivity always improve the outcome. And that those papers by Dr. Miller and other groups showing exactly that, the more engagement, the better the outcome. So that's why I think it's important to, in our mind, to separate what is the purpose of the neuroimaging or head ultrasound that I'm doing. Is it outcome measure, or is it to counsel the family?
Well, that is a great discussion, because it's hard to predict what is going to come out of those conversations. And I mean, in a lot of cases, what is predicted doesn't really happen when the families have the proper support, early intervention, as you mentioned, and as you actually showcase some of those children. I think that is difficult for families, because sometimes, actually, we're discussing this over the last weekend at the conference, is it taking the hope away from families, right? Hope that, and to be honest with you, I really don't like the term good or bad outcomes, because bringing my son home from the NICU was a great outcome, because he made it through that crazy NICU journey. He does have cerebral palsy. Some clinicians see as a bad outcome, but for us, we never see as a bad or good outcome. It's just our child. And I think the conversation, in our opinion, as parents, and a lot of us, have to change from there, right? How do you define what is a good and bad outcome? And then what is the hope for the families, right? That we can really work hard with our children to maximize their potential and live a fulfilled life, because our children are not less than because they might have a disability. And I think that is always a difficult conversation, right? Especially when you talk about the brain and the possible, what is going to happen after when you leave the ICU. But I so much appreciate the work that you're doing to really and nurturing the brain. I think that is already a change in the thinking. How can you nurture the brain and look at the brain as a brain health rather than the deficits that the preterm brain can have? So one more question for you before we go to Flavia. So these babies, are you following them up in the neonatal follow-up clinics to see what is happening to them in the community? Because the bundle is relatively new. And how far ahead are you following these babies to see where they are and how they have been progressing?
Yeah, and just one comment before I answer your question. I can't agree with you more. And we have to say that to the families when we have to mention the term, you need to be careful not to losing hope. And we have to mention explicitly that hope is the main indicator to improve the outcome. So that's why I try to maintain hope, to try to keep the hope. And this neurotypical and bad and good outcome, we have lots of work from physician side to change our language, to change our mindset and stop mentioning those terms, because each child is different and each family is different, and we can't lump them into numbers and diagnoses and labels. That is very, very important. We do follow them up, and that the long-term paper was showing that there was less cerebral palsy and neurodevelopmental impairment. Those were the 18 to 21 month outcome. And then the follow-up clinic followed them up until 3 years. Beyond that, they go to pediatricians and our neurology clinics, but we don't have measurable outcome like the Baileys after that and any other a standardized way of measuring the outcome, but up to 3 years, we do follow them up.
That is wonderful. Dr. Mohammad, thank you so much for joining me here today. Always a pleasure talking to you, learning from you, and I'm so grateful that you're really paving that path for many other clinicians coming after you to change the way we communicate and change the language in ICU and see these babies really thrive in the community. So thank you so much.
It's my pleasure, Fabiana, and I learn from you guys. I have learned a lot from parents, and I enjoy learning from parents. So I am the one who should thank you. Thank you very much.
Wow, it was a great conversation with Dr. Mohammad, and I hope you enjoyed. If you do have questions, please follow him on Twitter. He'll be happy to answer your questions. And now I have here join me live from Calgary, Flávia Sant'Anna, who is a premi mother who immigrated from Brazil to Canada in 2014. Her daughter was born at 23 weeks in 2017. Since then, Flavia and her husband have been navigating the challenging journey of prematurity while helping others and learning from their perspectives and experiences. Today, her daughter is 5 years old. I'm sure you saw her at the presentation from Dr. Mohammad. Her and her husband continued their advocacy path for her. Flavia, thank you so much for joining me here today. It's so great to have another fellow Brazilian mom joining our community. I'm super grateful to have you sharing your story today.
Thank you so much, Fabiana, for the opportunity, and thanks to Dr. Khorshid as well for the invitation.
And sorry, just to all of you watching us live, please do send your questions because I'll do a Q&A with Flavia after her presentation. Flavia, the floor is yours.
Thank you so much, Fabiana. So yes, my name is Flavia. I met Dr. Khorshid when my daughter was still in the NICU, and I came to present a little bit of our journey so far. Next, please. Myself and my husband, we are originally from Brazil. We immigrated to Canada about 9 years ago, and we have a dog, and we have Lena, our little one that was born premature. Next, please. So how did we end up in the NICU? Lena was my first pregnancy in 2017. Aside from having polycystic ovary syndrome, I was fairly healthy. But because of the length of time that I was suffering with PCOS, several doctors told me that I would have to undergo fertility treatments to get pregnant. But fortunately, Lena was conceived naturally, but it did not come with its complications. So I actually found out that I was pregnant because I was having bloody loss. And when a pregnancy test was done, it came back positive. We found out a few weeks after the bleed started that I had actually a subchorionic hematoma that was active, that had an active bleed. And at 19 weeks, it was found that Lena had a plexus cyst, but everything was considered normal for a first pregnancy, and especially from a pregnancy from someone who suffers from PCOS. So I was put on modified bed rest, and the subchorionic hematoma started to shrink. Then I came back on a new routine with some restrictions in order to improve the outcomes. But then I started to have the first signs of early labor. So I lost the mucus plug, and a few weeks later, I was in active labor. Next one, please. I had a very complex birth at 23 weeks. I was submitted to an emergency C-section. So that means that I had absolutely no time for steroids or any other type of measure that could help improve the outcome of a premature baby. I did have some magnesium drip while I was performing the C-section, and the doctor said that the magnesium drip would probably help somehow to offer Lena's brain some protection. They found out during surgery that I had a very unhealthy placenta, so the subchorionic hematoma had actually become necrotized, and I had a uterine septum that was not seen in any of the ultrasound. So those a few reasons that collaborated for Lena's early birth. But because Lena was already in fetal suffering for a while at the moment of the C-section, she had a coding event 2 minutes after she was born. And they had to resuscitate her and rush her to the NICU. And I still remember that was one of the most terrifying times when you hear all the sounds from an operation room, but you don't hear any sounds from your baby. And I still remember when I met Lena for the first time, it was a picture taken by my husband, and I could only think about two things. The first one was, wow, she is just beautiful. And the second one was like, I can't believe that they have all the resources and the structure to keep a baby so tiny alive. But still, we did not give up any hopes. And that's when our NICU stay started. So we tried to make sense of what was happening. After I was transferred from surgery recovery, we had a doctor coming in and talking to us, explaining all the odds that could happen to a baby born so early. We were literally introduced to all the statistics and numbers, and none of them were happy numbers. My husband and I were always set on stone that we would have our daughter anyways. It doesn't matter what the future or the prognosis would be. We would be at her side no matter what. We became very familiar with two expressions that I think that a lot of parents that face NICU are familiar with. It was the honeymoon, basically the first 3 days that the baby is born. So they seem to be doing well, they are stable. And then you literally sign up to live in a very wild roller coaster. So one day your baby will be very nice, doing okay. And the other day they will be facing the worst nightmares. And that's as well when we started to be introduced to the bundle. So for the first 3 days, we were offered the opportunity to contain Lena with our hands inside the incubator, but the manipulation was reduced to a minimum. We were in a separated room that was always kept with minimum lighting. There were very few procedures. They would try to combine all the procedures at once, so they were not manipulating her a lot. And we started to make sense of what was happening there. NICU with all the beeps, all the machines, all the medications, all the nurses coming back and forth, the respiratory therapists, it can be a very intimidating place for parents. And we started to think, what was our role there? Like, what are we supposed to do? We cannot care for our daughter as a regular newborn, so what are we doing here? And then we started to understand what a NICU dynamic would look like for our family. And one of the things that we decided was to taking part in researches and surveys. When I saw Lena for the first time, and I thought about all the things that they were doing to keep her alive, I then rationalized that for Lena to have the support that she had at that point, they had to conduct long researches and studies and see what worked and what did not. So we decided to take part in researches and surveys to make sure that babies born after Lena would have more chances to stay alive. Next, please. So that's myself holding Lena for the first time when she was 3 days old. It was a very emotional moment for myself and for my husband as well. Our NICU stay was very long and eventful. So I normally call the hospitals our homes. So our first home was at Foothills Medical Center, where most of the life-threatening events happen. And from life-threatening events, I mean all the terrible things that sometimes can happen to a premature baby. Lena needed PDA ligation, she had NEC, she had spontaneous bowel perforation, bilateral kidney failure, you name it. She had everything. And she was always being followed up with brain ultrasounds, and fortunately, she had absolutely no brain bleeds during those times. We started to get more involved in Lena's care. So my routine was basically being at the hospital from morning to evening. And I wanted to know everything. I wanted to be involved in her diaper change. I wanted to know which medications she was on. And that's how we started to learn more from the team and from other parents on how to advocate better for her. And that's when I started to participate on rounds and literally discuss with doctors and set up goals together, because we were not letting anybody giving up on her. Our second home was Alberta Children's Hospital, and that was a very stressful transition, not only because Lena had, not Lena only, like our whole family would have to adapt to a new environment and a new team, but because Elena had some complications with her breathing tube during the transference. And we were always wondered how this could affect her. We started to see the importance of having both parents present. Lena reached a stage that she was clearly able to know when her dad was around, and she loved his voice, his touch. And for us, we cannot imagine what Nick would have looked like if only one parent was allowed there. Our third home was Peter Lougheed Center. I had the opportunity to rooming with Lena for 2 months, and I was barely coming home at that point because I wanted really to be hands-on with her care. I wanted to know everything and make sure that I was fully prepared to take her home, although there is no amount of time or training that can prepare a parent to leave home by themselves with a baby that is so tiny and fragile. Next, please. So after almost 155 days, we had some setbacks during week discharge. Lena had some GI issues, and we had an MRI canceled twice because they did not have a machine that was small enough to monitor her during the procedure. So we were discharged with an outpatient request to do a brain MRI. And we were discouraged by several doctors because it wouldn't change the course of her treatment plan. That we would learn after years that it was a very important complementary exam that could have changed the way that we handled her care for all the years. We started to get ready to take Lena home. So we had a home readiness plan in place. We started to ask questions: what was allowed, what was ideal. We had a stock on her medication. We had the nurses training us on how to proper feed her. So we basically asked everything, and we were so grateful that all of our questions were welcomed with an open heart by the team, because we wanted to make sure that we were doing the best for her. And I always told Lena that she could stay in the NICU for how long she wanted, but once we were home, we were not coming back ever again. And we had to say our hospital goodbyes. During the process, we befriended lots of parents. We saw many families coming into the hospital and leaving the hospital empty-handed. And I just honor those families who had to face such hard times as well. The picture is a little note from some of our NICU nurses. They were just like encouraging words and phrases, and I was trained by them on how to use the machines and to feed Helena, because that's how much involved we wanted to be on her care and make sure that we were bringing her home to a safe place and where she could have the best possibilities to thrive. Next, please. We had a few bumps on the road too, so it was not always easy to go home with a baby. That's Dad doing his first kangaroo care with Elena when she was about 1.5 kilos. So the first few months at home were extremely difficult to adapt to because of the new routine. Lena had several medications. We had to take up lots of fights with medical benefits to cover medications that were very important to keep her alive. She had several medical appointments that required in-hospital presence as well. So we were always full of fear, exhaustion, and hopes that everything would be okay in the end. But we learned that there is no end. It's just a process. And that's when we started to have to advocate more fiercely for Lena. We started to see some early signs of difficulties in her development. And all we could hear was that she would turn out fine because the exams were clean. There was nothing wrong happening with her brain. So we were always assured that she would turn out fine. And when we started to push a little bit more for proper developmental assessments and a brain MRI and genetic testing, we found out that everything was all right because we were trying to do our best and advocating for her early intervention. Our main goal with getting answers for what was happening with our daughter was to obtain knowledge. And it's not a cliche when people say that knowledge is power. It doesn't define your child knowing the possibilities. It's just to educate ourselves for better parenting and educate ourselves to advocate for the proper support that our children will need. Next, please. And what does the future look like? We know that Lena's outcomes were greatly improved by the amazing support that she had in the NICU, by the early intervention, and that we included all the hard work that we did behind the scenes when she still didn't have a label that could offer her a chance to access proper services. And we find that continuity in care across environments is something very important. If you have the whole team communicating and on the same page, there is absolutely no way that the best treatment plan is in place for your child. we found a very interesting relation between diagnosis and access to support. Basically, when Lena was very young and we started to see the first struggles with her development, she was not able to get a clear diagnosis of what was happening to her. And that was a factor that greatly limited our access to support through the system. So we decided to go by ourselves and talk to specialists and do our research and basically talking to other families and see what we could do in order to better support her. And that's our little one when she was still at PLC. And now meet the girl who goes places. Lena is now, as Fabiana said, almost, she's 5 years old, almost 6. She is an absolutely joy. She has the best smile ever. And despite everything that she went through, I take so much pride on this girl because of her resilience, her courage. And every day she showed us that she was meant to be here and that she proved so many people wrong. We had so many conversations because doctors wanted us to just stop the interventions and just put her on palliative care. And we refused it so many times because we always thought that if she was not meant to be here, she would let us know. And just to see how she loves and she enjoys being alive is the best reward ever. Next, please. And if we could say something to the healthcare team is to please get to know the family we're working with. Our family wanted to know every single detail about our daughter's treatment plan and what would be the probable outcomes and how we could better work to help her thrive and which kind of supports we would have in place. We met other families that they did not want to know all the small details. So I think the best way to start is getting to know the family we're working with and know the amount and the information and how they want that information delivered. Please get to know your colleagues. It was extremely frustrating to enter a NICU room and find half of the team trying so hard to save Elena's life and the other half just telling the other half just to give up. So you are allowed to disagree on treatment plans, but if the family decides what are the goals, please just keep that in mind that you cannot just go in and say that you are not doing something. Please think outside of the box. The protocols are in there for a reason, but we are still human beings. We are individuals and we are unique. Sometimes there will be a lot of people that do not fall into the protocols. And when that happens, sometimes we just have to think about different opportunities and different options to give these people a chance. Do not hold back on using the system. So complementary exams and the specialists are there to help you make the best choices. So if you don't have all the answers, just keep looking for it. Just ask somebody, give somebody a call. That can really make a difference. And if we could say something to the families is spend quality time with your baby and with your family. We do not have another child, so I can begin to imagine what it is a NICU stay when you have half of your family at home and the other half has to be at the hospital supporting your baby. But try to your best to be there for both. Please take care of yourself. This one is so taken for granted, and it's hard for us when we are in the midst of the chaos just to stop and take a breath and just take care of ourselves. And we can do that even by asking for help and having access to resources. And please do not let the labels limit you or your child. We lost count of the times that every single concern that we had around Lena was considered from prematurity and that there was nothing else that could be done for her. So if you don't settle just for labels, your child will have opportunities that they wouldn't have, that he or she wouldn't have before. So don't let those labels discourage you or take the brightness in your child. They are just there as a mean to offer support and to have access to a system that not always offer easy access to certain early interventions or to certain specialists. Next, please. And again, I really appreciate Fabiana and Khorshid for this opportunity. And I hope that our family journey somehow can bring some hope for families that are facing the same or similar situations that we are. You are not alone, and reach out. I think that there is very important for you to know that you are not alone.
Wow, Flavia, thank you so much for sharing your journey, your story. Wow, I had tears in my eyes because you said so beautifully, the conversation with the doctors, how you and your husband navigate those difficult days, and the hope that you always had for Lena. So thank you so much for sharing all those pieces with us. I have so many questions for you, but for the sake of today's topic, because we really want to highlight the brain and the bundle, but I really wanted to come back because I want to unpack it way more for you. But I want to go back to the very first few days in the NICU when you were approached by the team to be part of this bundle for neuroprotection. And you talk on during your presentation about not knowing your role in the first few days, and then I see you as a parent. We had the honeymoon moment the last couple of days, and then you're enrolled in this bundle that you could not really hold her, but we could put your hands on her. So tell us a little bit more about that experience, and was the team helpful to you by explaining what they were doing? Because it's something fairly new that we really want to roll out because the results are incredible, but we really want to see from the family perspective. How did you receive that?
I think that after you give birth, the first thing you want, like if your baby was born premature or not, is just to hug and hold them. And for me, it was really hard, but at the same time, I was so afraid that I could cause her some harm. So when the team approached us and explained about the bundle and what they were trying to do, we felt actually very safe and comfortable with what they were doing. We were explained that babies born that sick and at that gestational age could have very high chances to have some type of brain damage, especially IVH. We were on board with everything that we could do to help Lena not to have it. If there was a slightly chance to prevent it, that's what we wanted. They explained it to us that they would do like very little manipulation, that the lights would be turned down as much as possible, no big, no loud noises. The doors from the room that she was at was kept closed. They were trying to just to get, like, it was very hard for us to see that our baby was born so sick and so small. But at the same time, when we started to feel like they were not trying to limit our access to her, it was very easy for us to understand. So we were still able to contain her in the incubator, but fear was always something that was surrounding us on those first days. And it happened exactly like that. On the first 3 days, she was really good. And after 3 days, that's when we started to see things happening. And we always had, like, we were always worried that somehow her brain would be compromised on this process. But we were very fortunate that the bundle and all the other interventions, despite her sickness, helped her not to have brain bleeds.
Okay, so let's talk about the brain a little bit, because there's a lot of conversations around, giving parents all these statistics, what can happen, what is the outcome. Can you talk a little bit about your experience and your perspective on that?
So as when I was being struck to, after I was discharged from the recovery room, as soon as I came to the infirmary, we had a doctor coming in and just giving us all the numbers, 24%, 20%, 10%. And all those numbers were very scary. And I do understand that they have to let us know that our child can have like very intense complications over their life course, but I don't feel like numbers were helpful at all. And at the same time, we start to think that each baby is a unique baby. So you can never know for sure what is going to happen. You just have to, I cannot say not even being prepared, because there is nothing that can prepare us for that. But just to keep in mind that those types of things can happen, but they are not the end of the world, and they are not going to define neither your family nor your child. I know that they have all these studies and statistics, but how the news were disclosed to us, we felt like kind of lost, that it was almost like a fate. There is nothing you can do. This is going to happen. There are very, very high chances, but still we know that each baby has a unique potential, and early intervention is really the key. We see major improvements on her overall behavior and development because of early intervention. Mm-hmm. So I feel like all those numbers, they are not helpful at all for parents, especially after they just gave birth. And they literally do not portray what we are seeing nowadays. There are so many babies that are they're able to live happy lives despite the gestational age. Of course, they might need some more medications or some more support, but that doesn't mean that they're not going to have a fulfilling and happy life.
Wow, Flavia, that I agree with you 100% on that. You mentioned something that was really got on me. We said half of the team was supportive to you, to your decision of doing whatever it takes to keep her alive. The other half of the team didn't. And they always, I mean, everything we are talking about goes back to communication, right? How you communicate to families, how do we engage with families, how do we break the news to families, how do we present results of tests and to families. And this was really important, I think, to you, because you said, I want this baby to, everything to be done to this baby while you're here. And how was that disconnection for you during that stay between teams having different approach to you and your family?
So basically, this was Lena had a massive pulmonary hemorrhage because her PDA opened, and we entered a room where they were performing CPR on her, and half of the team, like, they just were like, they have been doing this for so long. This is not and good. So it's good that you are here. You can say your last goodbyes. And then I look at the doctor and I asked, is it over? And he said, no, it's not over. She's still here and she's fighting. And that's when Lena opened her eyes and she looked straight to her dad. And I knew that she was there and that she wanted to stay alive. And I just asked him, like, can I hold her? Like, can I touch her? Yes. So they kept doing whatever they needed to do, like in terms of medical procedures. And her dad was there by her side. I was there holding her and singing to her and letting her know that whatever was her decision, we would be fine. But if she decided to stay, we would still fight for her the same way we fought all that time. And we could see like half of the team was just like, well, this is not going to end well. Don't give this family hopes. I don't think that this is going to work. And fortunately, Lena is such a little stubborn girl. And she said, well, let me prove you wrong. And she made it. And as I said, Fabiana, I know that sometimes things can look really bad. And I know that sometimes medical professionals or like healthcare team, they're just like a little bit scared to give parents some, like, a lot of hopes, and then those hopes not being fulfilled. But I feel like if the family is there, if the baby is showing clear signs that he or she wants to be alive. There are still so many things that can be done. For us was really like traumatizing, and that started like a whole circle of untrust between us and the team, and we wanted that to stop. So we had a clear conversation with the team again, and we put up conjoint goals, and we started to push for things, and that's how things happen. I think that clear communication is important, not only on the team's end but on the family's end as well. So we, like, English is not my first language, but all the time I refused to let English be a barrier for me to advocate for my daughter. So I would totally go and make myself fool and pronounce things wrong. And I didn't care. Like, you can correct me if needed, but I hope that you to understand what I'm trying to say, because if you don't have the whole team on the same page, it is so hard. And by the time that Lena was very sick after the PDA ligation, she had the syndrome after the ligation, and we were very honest with them. We told them that if something happened to her, we wanted to be there at her side, holding her. And they just said, well, can I be honest with you? And they said, please, so don't leave the hospital. So we didn't leave the hospital because there was like a very high chance for her to code again. And that's what we expected for teams. Like, the outcome can be hard, but honesty and open communication can really not offer false hopes to parents, but it can really clarify that the goals that the parents want are being followed and that they are reasonable. So if you don't have a clear and open communication with the team and vice versa, there is no way that the care will be properly delivered. And in the end of the day, the babies will be the ones suffering.
Wow, Flavia, it's incredible. Thank you so much for sharing your story, your experience with us. I can totally relate on the English as a second language on that one. But it's incredible the work that you did. And I know you are already volunteering in the hospital, bringing the voice and your perspective and how can we improve care together. And I'm so grateful to Dr. Mohammad for being so open to listen to families. And he's so incredible because he really shares how much he's learned from families and work together to improve care. So thank you, Dr. Mohammad. I know you're going to be listening to our recording later. And Flavia, thank you so much for joining us here today. I'm super grateful to have you with us.
Thank you so much, Fabiana, for the opportunity. Thanks for Dr. Khorshid for sharing his expertise. And I just hope that other families reach out, because you are not alone and you can get support and find people to just help you and support you through this process. It's not easy, but we can make it through together.
Absolutely. Thank you, Flavia. And to all of you watching us live today, thank you so much for joining this episode of the Premi Chats, and a special thanks to AstraZeneca, who makes education sessions like this one possible. Just a reminder that if you miss part of today's session, head over to canadianpremis.org. Let me share the website here. And to see this episode, and also all the past sessions of our Premi Chats. You find many resources and support options available there. And you also be reminded that CPBF is a charitable organization and depends on support to continue its important work. Consider how you can support CPBF and its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all our preemies and their families. And we will see you again next Friday, 1 p.m. Eastern Time. Stay well.